Good morning, good afternoon, good evening, good late night, depending on where you are in the world. As we've shared a few times, a little over half of our viewers now are coming in from outside of the United States. There's a global interest in improving your health. Today, we're going to be talking about a topic that just continues to come back. There's a lot of fear and concern about artificial sweeteners. On the other hand, there's a whole lot of folks out there with weight problems, food addiction issues, and specifically some food addiction issues around sweets. I'm one of them. I've had a sweets addiction for a very, very long time. The concern here is a health concern. Artificial sweeteners have been used for decades. And one of the first big issues that came out of the blogs was a concern that an artificial sweetener might cause bladder cancer. Well, as you started looking a little bit more deeply, yep, that was true. The sweetener we're talking about was saccharin. The reality was, if you actually did the biology, that information was developed using laboratory animals, lab rats. And if you transferred that risk to humans would have to ingest about a pickup truck load full every day of saccharin to have that kind of significant risk for bladder cancer. So this is a thorny issue for folks that, again, have sweets addictions and problems associated with weight. If you look at it, that may sound like a small group, but really it is the biggest group in terms of risk. Yes, heart attack and stroke risk, they are the biggest for folks that are, once we become boomers, middle-aged. But weight, excess body fat is almost always an issue there. And yes, food issues, sweets addictions are almost always an issue as well. So we'll talk a little bit more about that. We're basically going to focus a little bit more on one article. We're not going to get too deep into that article, but again, it's more to raise this discussion and talk about the pros and cons, the benefits and risks of artificial sweeteners. Before we do, we'll go into some other issues. The Prevention Myths book is continuing to raise interest. We continue to get a lot of folks who are buying it, reading it, saying, look, you know what? You didn't give that book enough credit. It's very, very helpful, and it's far more readable than you said. So again, I appreciate the interest in the book. Basically, it's about the myth. One of the myths that, hey, doc, my cousin had a heart attack. I'm worried about my risk. Could we get a stress test? Oh, no. But think about it. Learn what you're getting into before you start going down that slippery slope of stress test, then going to the cath lab, and then getting a stent. Again, you may end up needing a stent at some point in your life, but stents don't prevent heart attacks. That's an incorrect assumption that it's just plumbing. It's metabolism. It's not plumbing. If you don't know what I mean by that, then maybe you haven't seen enough of our videos in our channel. We're a channel which is all about helping folks, no matter what country you're in, avoid the biggest cause of death, heart attack, and the biggest cause of disability still in most areas is strokes. It also helps us avoid risk for what's becoming one of the bigger causes of disability, permanent disability, and that's dementia. Alzheimer's is now being called type 3 diabetes. That's why these issues, unrecognized, undiagnosed, prediabetes, and even full-blown diabetes are so critical to our health. So this channel, we get into that information, and here's why. Because unfortunately, your typical doc does not know enough about how to diagnose these issues, especially prediabetes, the number one risk factor. They don't know how to diagnose it, let alone how to manage it. And so it's not just me. Look at other sources. Look it up. Check my facts on this. At least 90% of people that have prediabetes don't know it. So here's some other topics that push around this area and give us perspectives around how we can take control of our own health and add a couple of healthy decades to our lives. Sleep is a big issue, and it will continue to become more and more recognized. It is a place where we give our hormones a chance to readjust, regenerate. And hormones is what this is all about. Lean mass hyperresponders. Dave Feldman is a fellow he's an engineer. He's not a doc, but he's done a lot of really good research and focus in doing some great teaching on folks, where it's one of the more common things I get. I get a call and people say, well, hey, doc, I decreased my carbs on my diet, but my LDL went way up. I'm in trouble. My cardiologist is really worried. My doctor's really worried. Before you panic, before you stop taking that low carb diet, take a look at these videos. Think about it. Understand some things that, again, your general medical community is not quite there yet with. We are making a couple of changes in our webinar program. We're going to be focusing for the indefinite future on the gut sugar webinar. We've got our last supplements webinar and our last plaque management or plaque measurement webinar coming up over the next month or two. If you want to get in on one of those, go ahead and do that. We'll talk a little bit more about how we're going to be providing that content in the future. The courses are still there. They're still available, and they're still the financially most cost-effective way of learning what your doctor probably doesn't know or may not know about prediabetes, plaque, and heart attack and stroke prevention. Want to make a comment about, I'm down in Lower Alabama now, actually in the Mobile Clinic on Airport Road. The video today will be a little bit shorter because here's what's going on in Mobile. We started our newer, larger clinic here in the Mobile area, and the demand is just amazing. Huge number of people who need help and are excited coming in. So one of the things that happens when you start up a new clinic is you have to make adjustments. And right now, adjustments is not really the word. We've got patients coming in that are saying, yeah, I know you're a chronic disease clinic. I know you're a disease management clinic, but look, I'm sick. I have tried to get into my doctor. I can't get into my doctor. I've tried to get into 4 urgent care clinics over the past weekend. None of them would accept me because they're not accepting patients. They're just overrun with a couple of viruses that are going around, in addition to, yes, Omicron. So we've got a lot of sick folks coming in, and we're getting them seen. The team here are heroes. They're doing great work. We're doing a lot. We're helping a lot of people, and we again had to make some significant adjustments in terms of long-term care, primary care, prevention. We're focusing right now a lot more on just helping some sick folks get through a very difficult time here in Mobile. And again, very proud of the team and what they're doing. As I mentioned before, we continue to go through some of the details in the prevention book because there's a lot of them there. And again, this is all about maybe a little bit better way of taking care of your health than just saying, hey, doc, can we get a stress test? because you know what? That's what Tim Russert said. He did fine. He passed his stress test with flying colors. And then if you don't know, he died. So let's make sure that those of you viewing this don't go down that same path. So artificial sweeteners. You know, there's again this whole concern that do artificial sweeteners cause insulin resistance? I will tell you this. Again, it is not so easy to just make that assumption. It's not so, because of some of the things that I talked about. For example, there's a thing called participation bias. What does that mean? Well, bias means you may see a finding in a study, but it may not be real. In other words, you may have selected, and that's another epidemiological term. You may have selected for people without thinking about it. So, for example, that is a big deal with artificial sweetener research. So, the simplest and easiest way to do a artificial sweetener study is to say, okay, we're just going to do what's called a cross-sectional study. Cross-section means you just take a one-time sample from a large population. So you get people and you say, okay, just get people on the street at random and say, okay, do you take artificial sweeteners? And then you look at the ones that have that say yes, and the ones that say no, I don't. There's no question if you do that kind of study, and there's been tons of those done, where the findings were, guess what? Yes, of course, the people that said, yes, I drink diet sodas, I use artificial sweetener in my coffee or tea, those folks are more likely to have insulin resistance, prediabetes. Well, gosh, does that mean that the artificial sweeteners cause that insulin resistance, that prediabetes? Not so fast. Who's most likely to use it? People that are thin and do not have a weight problem, or people that have a little bit of a weight problem and are trying to keep their weight down? I think it's immediately obvious. Artificial sweeteners are going to be used much more often by people that have a weight problem. They have made their assessment. They've decided they've got too much body fat, and they still have some food addictive traits, and they want their coffee sweetened. They want to drink diet sodas. They want their tea sweetened, and so they use artificial sweeteners. It is incredibly common. So, can you trust a study that's just a basic random cross-sectional study that says, okay, we took people at random. The people that use artificial sweeteners have insulin resistance. I would not use that. I mean, that is very, very weak. There are tons of those studies in the quote science, the literature, and every one of those I would ignore because I don't think they get it beyond a very, very obvious initial issue with participation bias or selection bias. You're selecting for people that are going to have a weight problem. And what's the number one cause? You thought I was going to say a weight problem. No, the number one cause of insulin resistance is age. But weight is a very strong and very close number two. So are there some studies that go a little bit deeper? Yes, there are. And here's the issue. I saw a study that was fairly good about 2 years ago, and it was focused on, I think, sucralose, one of the things that's used very often in diet sodas, diet Cokes, diet soda pop type drinks. And there was some significant number, but it was not very big. Now, here's another study. And as I go a little bit deeper into the details on this study, there were just so many things that weren't covered. Again, another example of how you look at this study and say, how solid is that in terms of those of us looking for proof that artificial sweeteners cause insulin resistance? So let's talk about the study. First of all, where did we find it? Journal of Family Medicine and Primary Care, the official journal of the Academy of Family Physicians of India. Not a bad journal, but clearly not the New England Journal of Medicine, not one of the top 5 journals in the world. It's just, and if you have information that's both important and very, very solid, you're going to go for the best journal you can go for. But let's talk a little bit more about it. What's the title? Effect of artificial sweeteners on insulin resistance among type 2 diabetes patients. Well, now, wait a minute. Let's go back and ask another question. Talk about selection. We've already selected people that have type 2 diabetes. In other words, people that already have, by definition, big amounts of insulin resistance, not prediabetes, but already diagnosed with type 2 diabetes. So that automatically starts raising a question in my mind. What are they actually looking for? So we'll go a little bit deeper. So the hypothesis that they looked at in this article was, okay, artificial sweetening agents have broadly replaced other forms of sugars. Usually ingestion of artificial sweeteners, AS is the term they're using, it results in the release of insulin. Now that's, again, a hypothesis. Results in the release of insulin from the pancreas, which is mistaken. In other words, the artificial sweetener is mistaken for glucose. Again, I look at that and I start saying, really? How much evidence do we have of that? Because our taste buds, certain taste buds recognize this is a sweet taste. Does our body biochemically recognize this as increased blood sugar? That mechanism doesn't make sense to me. We have what's I think it's not the ventromedial nucleus. There's a nucleus in our brain, which is sort of like a thermostat in a building, a heat thermostat. It measures the heat. If the heat goes up too high, it turns the heater off. If the temperature goes too low, it turns the heater back on. So why would that be? Are we absolutely sure that nucleus in our brain is recognizing artificial sweeteners as the same as it does glucose? Again, another significant leap in terms of assumptions. The increase of the levels of insulin in blood eventually lead to decreased receptor activity. Now, again, that one is a little bit more believable, but also, again, it's a little bit more believable, but it's a stretch because there are two major mechanisms for development of insulin resistance. One is age, and the other is body fat. Neither of those is the initial problem, release of too much insulin. At least that, again, as you see, I'm struggling with that one. Yes, there's clearly, with insulin resistance, you see release of too much insulin. There's no question about that. With body fat problems, again, you start seeing release of cytokines, other chemicals, which impact our insulin receptors. With aging, it's not quite, again, so clear how and why that insulin develops, that insulin resistance develops. Now, here's one thing that is clear, and that does lend some credibility to that assumption. Once you start getting insulin resistance, then your fasting insulin starts to climb up and up and up, because it takes more insulin on a regular basis, even when you're fasting, to keep your blood sugars at normal, healthy levels. So again, let's go a little bit further into this study. Methodology. The authors performed a cross-sectional study. So again, very similar to the type of study we talked about before. Not quite so much a study. It's not a randomized clinical trial. You're not taking a group, randomizing one group, breaking it into two or more groups, randomizing groups to a study group and a placebo group. There's none of that. This is, again, just a cross-sectional study, similar to the type that we talked about before. You take a bunch of patients, you do a measurement on them, and you ask them if they were using artificial sweeteners. And again, these were patients that already had type 2 diabetes. This was in a hospital in central India. So all the diabetic patients were divided into two groups based on whether they use artificial sweeteners, group A or group B. So again, now you've created a dichotomy, and the question is, how and where did you dichotomize that? Did you say, okay, one sweetener per day or X amount of milligrams of a sweetener? Which sweeteners did you look at? Again, some questions which I don't think are that critical. But again, questions which come up as you start to get a little bit deeper in terms of trying to analyze a study which says artificial sweetener causes insulin resistance. So then the next item was they measured insulin resistance using a calculation of HOMA-IR. HOMA-IR is considered by many to be the gold standard for measuring insulin resistance. Here's how you do that. HOMA-IR stands for homeostatic method assessment of insulin resistance. And here's what you do. You measure the blood glucose in milligrams per deciliter. You multiply that times the insulin level, and you divide that by 405. So basically what you're doing, and it is an appropriate thing. It's very helpful. And quite often it's right, but not always. So the question is, excuse me, how much insulin is it taking you to get to an appropriate healthy level of glucose? Optimum would be 5 or less on the insulin number, and optimum would be 90 or less on the glucose number. And again, here's the problem with that assumption. You see it quite often. It's helpful quite often. It's clearly better than the most common thing that's used. The most common thing is not to look. The second most common thing is that the doctor uses only fasting glucose. And it's much, much better to add fasting insulin to that value. So from those perspectives, it's clearly better than the standard, but I see it all the time. I see it a lot. Maybe 20% of the patients that I see that have very significant insulin resistance, once you challenge them, had a normal HOMA-IR in the fasting state. That is the problem with HOMA-IR. It is a snapshot, a fasting state snapshot, and it's not a response to a challenge. Insulin sensitivity, IS, is calculated using the following formula. Insulin sensitivity is 1 over the HOMA-IR. So that's what they actually used. HOMA-IR, Again, it's an insulin resistance score. It was developed in 1985. Again, you see comments on our channel all the time. Oh, I got my HOMA IR, so that's the best thing there. Again, yes, it's a lot better than a fasting glucose. And in some ways, it's better than an A1C. You know, HOMA IR and A1C are very, very different ways of estimating this problem. A1C actually has the advantage in that it has more of a long-term picture. But again, none of them are as good as an OGTT with insulin response, oral glucose tolerance test with insulin response, more commonly known as the Kraft Insulin Survey. So again, that's what they used. And as we said before, they looked only at diabetics. So already it's like, So what the HOMA IR values in Group A range from 0.9 to 24.33. The HOMA IR values from Group B were 0.12 to 10.83. So the patients in Group A who had gave a history of using more artificial sweeteners, we're not really sure how clear that dichotomy was, as I mentioned before, did have higher HOMA IRs. So you've heard me criticize this study a lot in terms of a lot of different areas. By the way, if you're wondering what an epidemiologist does, and if you're wondering what I did those years when I was at Hopkins, that's what epidemiologists do. They look at the pros and the cons, the strengths and the weaknesses of studies to see, okay, you know, how strong is this study? If you look at normal values, by the way, quote, normal values for an IR value, HOMA IR, less than 3, moderate insulin resistance 3 to 5, and severe insulin resistance 5 and above. So the American Heart, a couple of comments on the discussion, and then we'll open it up to Q&A. The American Heart Association and the American Diabetes Association have cautioned not to use artificial sweeteners in place of sugars to combat obesity, metabolic syndrome, and diabetes. And they've done that based on studies like the one we talked about today. According to some studies, an important reason for development of diabetes is believed to be artificial sweeteners. I'm skeptical. In one study, people were given either sucralose or water and then subjected to a glucose tolerance test. Now that study, that's the one that I mentioned a couple of years ago that came out. That study, to me, gives me more pause for concern than any of the other studies I've seen. Those given sucralose had higher blood insulin levels. So, you know what? As I mentioned, I'm a sweets addict. I have used a lot of artificial sweeteners in my life. You could say, well, Ford, you know, you're a critic of these studies. That's why you're criticizing. Well, it may be. We all bring our biases to the table. But I can tell you, I still had some artificial sweeteners, some diet sodas in my pantry. When I read this study about sucralose, I went through the exercise of throwing those diet sodas away. Now, I'm an addict. I'm a strong addict in that space, and I keep going in and out, in and out. Most recently, yep, I'm a little bit distracted in terms of the programs here in Lower Alabama, juggling that and the channel practice and the channel itself. And I'm back on my addiction. I fell off the wagon. I'm back drinking diet sodas. Has it caused me health problems? I think it might have. Has it caused my insulin resistance? No. It may have made it worse. It was not the primary cause. My primary causes are, number one, I'm old. I'm 64 years old. And it started happening in my mid to late 50s. And I continued to work with it. Number two, what's my second biggest risk? Again, body fat. I keep a BMI in the low 20s, but I keep a little bit of, I have more body fat than I want to have. That's a constant battle. Number three, epigenetics. I was a 10.5 pound baby. We used to think when I was born 64 years ago that was a fat, happy, healthy baby. Now we know every ounce over 8.5 pounds, you have increased that baby's risk for diabetes and prediabetes when they get older, when they get my age, is greatly increased. And so again, there's a lot of baby boomers out there like me who are a lot heavier than 8.5 pounds when they were born. There's another epigenetic thing that hasn't really been proven yet for humans, but we've seen it in laboratory animals, where if the father is obese at the time of fertilization, the second and the next generation and the second generation after that, the risk for those generations to have prediabetes and diabetes is multiplied. And yes, my dad was obese when I was fertilized, when I came to be. So I've got a lot of strikes against me. I'm not denying, I think artificial sweeteners have probably contributed a little bit, but nowhere near compared to my age, number one, some body fat, number two, and some significant epigenetics. So, a couple of more points before we get to the Q&A. A similar study was done in 2011. They compared the development of type 2 diabetes with consumption of artificial sweeteners, beverages, sugar sweetened beverages. The increased intake of artificial sweetened beverages increased the incidence of type 2 diabetes, suggesting insulin resistance as the obvious mechanism for type 2 diabetes. But again, suggesting yet another, some more smoke around this topic of artificial sweeteners and prediabetes. So at the end of the day, do I think that they cause it? Yes. But here's the question. How much and how big of a risk factor are they? We had the comment early on with Jason Fung's review or statement that there's a significant increase in heart attack and stroke risk for folks that have artificial sweeteners or that use them. Again, like I said, I have no doubt there is some increased risk. I do doubt how much that risk plays into the picture compared to the far more common and far bigger risks that we see. So there we go. Thank you for your interest. And if Gilbert, if you'll give us the next, give us a water ball or something, we'll go into Q&A. So here we go. Parker Reed, Happy New Year, and thank you for covering this topic. Dr. Jason Fung cites the increased risk of heart disease, over 40%, with artificial sweeteners in his book. And, that 40% may be true. You compare that to doubling and tripling and quadrupling and more, factors of 10 times for folks in terms of aging, and again, body fat issues, as well as sleep problems, maybe not quite as high. We're not 5 and 10x kind of things. 40%, yes, it's significant, but how significant compared to the others? I think that's the real question. Can't read that. Sorry. Margaret D. Good morning, Margaret. Lee Acapulco. Well, we're having a little glitch here. Leo Acapulco. Good morning from Orlando. Good morning, Leo. Thanks for joining us. ET himself. Stevia for me for 23 years. You know, when I do use artificial sweeteners, I do prefer stevia. If you look across the waterfront, there's sucralose. We mentioned the old one in the past, saccharin. There are tons of others at this point. Stevia has been able to keep itself out of trouble in terms of at least the science. So many of us think, you know what, of the bunch, stevia may be the healthiest. It certainly appears to be one of the healthiest. Yep, Ruby. Can't read it. Lisa Abineth. Amazing, Dr. Brewer. Thank you very much, Lisa. I appreciate that. I appreciate that. Gator Beer Geek. Do you think some of the issues with sweeteners could be the high glycemic bulking agents, dextrose, maltodextrin, including in the powdered form of the sweetener itself? Yes, you know, one of the things that I'm learning from you, Gator, is that the bulking agents that they use have a high glycemic value. And it's like, really? Now, I will say this, the bulking agents, even with the bulking agents, they're added to make it more of a bulk that you get with natural sugar. So you don't get a huge amount of bulk there. But again, it's a great question. Ruby, I think we're getting some piling on from some folks that aren't speaking English. Johnson Trigno, my cardiologist and general practitioner should both take all your courses. Neither one of them have a clue. Can I get them to order the testing that you recommended? Well, of course. And again, if you want to know the testing that we recommend, it's in those courses. So thank you so much, John. It appears that the Medicare doesn't cover. It's very frustrating. I agree. You know, we do a lot of primary Medicare coverage in the clinics in Alabama, and there's some things that they don't cover. For the most part, we're able to get what we need, but it would be nice if there were a few other things available and covered. Jill Schwartz, hi, is stevia okay? Like I said, I'm one of those folks. Given this is an issue near and dear to my heart and my belly and my palate, I do think of the group, stevia is the safest. LPG, $100 on $100 on a super chat. Thank you so much, LPG. You've been coming on for the past few weeks and helping us out, helping us get this information around the world. So thank you so much. I look at all aspects of health: genetics, nutrition, supplements, sleep, stress. That is the thing to look at. And every one of these things you've mentioned, LPG, are critical to long-term health. What are your views on red light therapy? There have been some very interesting studies on it. Great content as well. Well, I don't have a whole lot of knowledge on red light therapy. I've heard of it. I haven't done a lot of focus on it, and sorry that I can't speak to it. It does remind me of some of the issues in terms of blue light, in terms of sleep, and I do think there's some issues there. Clearly, sleep is very important. There are also some issues in terms of, I think, ultraviolet light for saunas, and the information that I saw for those types of saunas was actually pretty good and pretty supportive. Parker Reed, $10. Thank you so much, Parker. Really appreciate, again, can't tell you folks how much I appreciate your contributions. It helps us get this information out, and Parker, $10 helps us with the economies that we're working in. Gilbert's in the Philippines. $10 US goes a long way there. Discover Health. Are you an advocate and proponent of, and do you recommend chromium picolinate supplement? I do. I've looked at it. I am a strong advocate. No. Do I think it helps and there's a place for it? Yes. Is it the most common deficiency in terms of risk factors? Nowhere near it. And in fact, at the end of the day, you can't supplement your way out of a lifestyle problem. You can't stent your way. You can't bypass your way. If you've got a lifestyle problem, by far the most common issues, number one, again, age, but then again, number two, diet and body fat issues. Those are by far the most important. ET himself, taste bud, sweet taste thing, could be a placebo or a Maslow thing. Yeah, there's some pure addiction science involving this. There's no question. This is an addiction related issue. Mezzanine, good morning. Good morning to you. And there's some places to find. Gilbert's giving some information on how to get some more of our content. Tracy Stein, is stevia considered an artificial sweetener? Yes, of course. I don't use any of the other ones. There's a lot of people out there that's saying the same thing that you are, Tracy. And when, it's like that commercial, when I drink beer, I drink, was it Corona? Don't remember, but when I use artificial sweeteners, I clearly select for stevia. I use that in my morning coffee most of the times, by the way. Gator Bear Geek, is a HOMA IR adequate if you're on a ketone lifestyle, since you wouldn't really be challenging your body with glucose if truly following keto macros? Adequate for what? I mean, that's the question. Like I said, if your goal is to learn how much or measure how much insulin resistance you have, HOMA IR will get you there better than a fasting glucose, and it'll give you some information that you don't see with an A1C, but it is no replacement for an insulin survey, an OGTT with insulin response. It's just not the measurement. You bring up a good point, though. A lot of folks will say, I have a bad addiction to sweets. If I do that insulin survey, excuse me, just a minute. Yeah. If I, again, we've got patients just coming in the doors here. So I'm going to cover as many comments as I can, and then I'm going to need to jump off and start seeing some patients. We got some sick people here in Mobile. There are several patients that I have where we talk about it and we decide, you know what, we're not going to do the insulin response, the OGTT, because they have addictions, rip-roaring addictions, and they know if they take that sweet liquid and for the glucose challenge, they are going to fall off the wagon and then just head right down that addiction pathway. ET himself, they could be done with non-diabetics, monitor the liver release of glucose. Yeah, you really do wonder why that study that we covered, why did they pick diabetics already, which by definition have a significant problem? Are you an advocate? We talked about that. Craig Bax, Dr. Bax, at a minimal, artificial sweeteners are a gateway to the real thing, the gateway drug. No argument with that at all, Craig. I think they are a gateway drug. And there's evidence of change in the microbiome. That's one of the bigger issues I have. Really good point. We didn't talk about it today. And one of the questions is that the mechanism for an impact on insulin resistance? Is this a microbiome issue? I think there's no question that artificial sweeteners impact the microbiome. And there's also no question that the microbiome impacts insulin resistance. It's a major determinant of health. I think the questions are how much, which sweeteners, how much of an impact do they have? A lot of that stuff. Jackie Savoy, what about stevia? As we mentioned, stevia is the one that so far has appeared to be safest. John Panazzo, great to hear from you, John. Like you, I have a sweet tooth. After getting an adverse calcium score, I switched to plain carbonated water. I have too. I'm doing a lot more carbonated water this time at this point, John, than I ever have in my life. I'll make my own with a sparkle system, which I love. I no longer desire diet soft drinks. That is a big deal. Congratulations. And let me reread that. I no longer desire diet soft drinks. LPG, another $100 contribution. Thank you so much, LPG. This helps us get that information out there. We appreciate it. Do you practice intermittent fasting? Absolutely. I change up, but most of the time I do some form of intermittent fasting. You know, when you study the folks like Walter Longo and some of the others that are looking at that, they recommend getting breakfast and lunch. But here's the thing, I'm a human being and my patients are human beings too. It's much easier for most of us to skip breakfast than it is dinner. So you know what? I think if your best and most easily accessible version of intermittent fasting is to skip breakfast, I think that's still better than not intermittent fasting at all. Dr. Bax, we use the InBody 570 body composition analysis and encourage our patients to aim for the lowest possible visceral fat level as an easy to repeat indicator of insulin resistance. There's no question that body fat's an issue. There's also, I think, less question about visceral body fat, and I have to tell you, thanks for the comment. I will tell you this, there's still a lot of questions about the form of body fat analysis. Some of the imaging, SPECT scanning, for example, have much, much better numbers behind them, much better mechanism, but they're much more expensive. Are you proponent? Discover, please go back to the previous. We're getting, again, dogpiled with some questions that I'm not going to spend time on. Happy New Year. Tired looking for name. Tired, thank you so much for joining us today. And thank you for the contribution. My dad drank nothing but diet soda and used sweet and low. He got diabetes in his mid-40s. There you go. And his kidney failed in the mid-60s. So that's one of the major things to look out for. A lot of us get prediabetes. Most of us do. Does it have to go on to full-blown diabetes and kidney disease? No, it does not. That involves care. Folks, I usually try to get to cover all the questions. Again, we are just having so much demand here, and we've got people that need care. I'm going to have to drop it a little bit early, and thank you so much for attending today.